Good afternoon, everyone. You know, earlier this year, as you know, the Supreme Court made what I think is an absolutely disastrous decision around affirmative action. And so we labeled this section, "We Dissent," to express our disagreement with that decision. And I think the fundamental impact we think is going to happen to our efforts on diversity, equity, and inclusion. Today we have an extraordinary panel with you to talk about this. We're going to have a keynote presentation followed by a great panel to talk about the details. So I'd like to introduce our keynote speaker, who is Dean and the Harold Green Professor of Law at the George Washington University School of Law, and that's my good colleague and friend, Dayna, Bowen, Matthew, who to talk to us and give us a little sense of what actually the court did. Thank you.
Thank you. Good afternoon. Dr. George has told me I did not have to behave, so I'm going to start off by misbehaving. I know the title of this is supposed to be I Dissent, but I thought I'd come right out of the gate and tell you what I'm going to talk about is combating structural racism. Because I do believe that the agenda of the Supreme Court right now, and I don't want this to be repeated or recorded, but is to dismantle affirmative action as part of a structural racist agenda. There, I said it. So what I hope to do in the next 15 minutes is go through 5 points. First, I'm going to talk about education and its connection to health, particularly higher education. Second, I'm going to take you to law school for just a little bit. If you'll buckle your seatbelts and sit with me, I'll talk to you about why law affects population health, what law affects population health, and how law works in this affirmative action decision to adversely affect population health. I'll end with some recommendations. So I'm going to go pretty fast so that we can get through the whole thing and get to the panel, because the panel is outstanding. So first of all, because I am very grateful that you had the courage to invite a lawyer among you as scientists, physicians, public health experts, I'm going to do a little bit of epidemiology just to let you know that the context of the law that I am hoping to teach you is going to be respectful of your expertise and respectful of the fact that I am a guest in your arena. So this is a study or a conceptual framework from a study done by Hahn and Truman. And what they do in this study is basically connect conceptually what education does to impact health. Now, whether it's in any of the 3 areas, psychosocial areas, that is creating a social group, a network of people that have at their core the kind of educational values that will drub off on you. Your mother said it like this: you are the company you keep. That's the first thing that education does. Secondly, in the middle of this diagram, it describes the work that is available to you if you have educational attainment in the United States. So unemployment goes down, wages go up, your employability goes up, and all of this is directly impacted by health. Educational attainment affects your work and therefore your health outcomes. Lastly, educational attainment affects your health literacy, your health behavior. This is all familiar to you conceptually, and what Truman and Hahn have done is they have said that a person who lacks the basic elements of education is basically not healthy. Okay, there's the conceptual framework. Now for the data. I'm just going to do one study because you are familiar with it. This is a study from demography, and it was done by a group of physicians who did a beautiful job of taking longitudinal data and looking at the impact of health attainment on different life expectancy. Now, I don't know where I'm supposed to be pointing that. There it is. All right. Of different racial, ethnic, and gender groups. And what you see here is the risk of death progressively going down as educational attainment increases. Now, this is very simply important because there are two breakpoints. One, high school. Your risk of death goes down precipitously if you complete high school, and then also if you complete college. This is just the data and the conceptual framework, but let me tell you, if the data doesn't convince you, I will tell you a story that I think will. I want you to meet my parents. This is May and Vincent Bowen. Vincent is 48 in this picture. He's a little wide around the middle. My mother is 47 in this picture. The next year, my father would be dead. So my father was remarkable. He was unique. He was exceptional. But his early death was not. I tell you the story not just because I want you to get to know me, which I do, and I want you to get to know my parents, but it is because their story is so not unique. My parents died in part, and I argue in no trivial small part, because of structural racism. Because of what they had to do to make sure that I could get an education so that I could stand here before you today. So my father went to school at night, City College of New York, for anybody who's from New York City. City College of New York, got his BA, and we lived in the South Bronx. So I was the proud daughter of a man who put on a suit and tie every morning and strode up Ward Avenue so that he could go on the number 6 train down to Grand Central Station and work as a real estate banker. He'd ride that train back at the end of the day and again stride down our South Bronx streets looking just as fine as he wanted to look, eat dinner, take a nap, go back in a pair of overalls and drive that same train for 8 hours. You do that for a couple of years and add 2 other side jobs to the side and you will die at 49. My mother died younger than I am today. Of course, I'm not going to tell you that age. But she died prematurely also. Why? This is the school that I went to in 1st, 2nd, 3rd, and 4th grade. If I had gone to this school, I would not be standing here today. Nobody on my block who went to the public school that this school fed is either out of jail, alive, and drug-free. Not a single one of my friends that went to this public school and the middle school that followed it stayed out of jail, drug-free, and alive. So instead, my parents worked 6 jobs between them in order to get me to this bucolic, beautiful school 7 miles away. Why? Because education was our ticket out. They knew, even though the data and the conceptual framework that I've shared with you is not familiar to them, that the only way I would stand here before you and be able to claim that I'm dean of anything or PhD of anything at all is if I got to this school instead of the schools that were in my neighborhood. They died because they had to work enough jobs to afford the $4,000 that was required for my brother and I to go here. That is because of structural racism. That is because in the South Bronx, everyone who looked like them, was paid like them, did not get paid a living wage, did not breathe the same clean air and drink the same clean water that my colleagues at Fieldston in this bucolic picture and the high school I went to drank. This is another way of saying that place matters. And in order to get me from one school, PS 93, to this school, Fieldston, so that I could stand here before you, my parents had to work 6 jobs. That's what I mean by the educational attainment connection between poor health and poor health outcomes. So now, what's law got to do it? Why do you have me, a lawyer, speaking to you today? Well, it's because you've seen this diagram. You've seen that the social determinants of health are the most impactful of any health outcome. Not your genealogy, not your genes, not your biology, not your clinical access, but that large blue pie slice that tells you that your social and economic factors are 40% determinatives of what health will look like for you and your community. And by the way, the other large slice, the red one, health behaviors, is largely impacted by social and economic conditions also. After all, if I don't have a safe street to walk on, if I don't have a tennis court nearby, if I have violence on my streets, Or if I work 2 swing shifts, I am not going to go out and go jogging at night to stay healthy. But here's the kicker. We've concentrated on clinical care. We've concentrated on making sure that we reduce bias, that we reduce prejudice, that we reduce all of the impacts of the clinical encounter in this very important study. This very important study that is a consensus study done by the Institute of Medicine, now the National Academies of Medicine, focused on bias and prejudice in clinical care. What I want to do for the rest of the time that I have to speak with you is talk to you not about bias in clinical care, but I want to talk about that large pie slice where unjust discrimination characterizes every one of the social determinants of health. Think about it for a moment. Think about my parents. The wages that they earned, unjust discrimination. The school system that they tried to get me out of, unjust discrimination. What characterizes, as I said, the air that we breathed in the South Bronx, the water that we drank in the South Bronx, the food that we ate in the South Bronx, unjust discrimination. And as a result, the relationship between discrimination and law is imperative. Imperative if we intend to create health equity. Law is essential to health equity. All right, so let's talk about civil rights law and what law actually affects the population. Here is where you'll need your seatbelt. I'm going to take you to law school for a little bit. So what law is it that affects health populations? Let's start with the Constitution, because that's where we start in law school. And the Constitution, as you know, was a document that changed dramatically after the Civil War. After the Civil War, there were 4 amendments, really 3 that matter to you today. 3 amendments that we call the Reconstruction Era amendments. Now, the Reconstruction Era was a 12-year period where equality really meant something under the law, right? I'm showing here 9 of the black elected federal officials who absolutely represented equality in voting, equality in education, equality in businesses. We had a heyday of equality during Reconstruction, and the law was no different. The law that was amended to the Constitution was 3 statutes, 3 amendments that are familiar to you. The 13th Amendment, because it freed, yes. The 14th Amendment, because it has the equal protection statute. And the 15th Amendment, because it gave the right to vote despite your race. And these 3 amendments are called the Reconstruction Amendments. Now, the one I want you to pay most attention to is the 14th Amendment, because it has something called the Equal Protection Clause. And out of the Equal Protection Clause comes all the civil rights legislation that you are familiar with that followed after the Constitution was amended during the Reconstruction period. Now, the one I really want you to concentrate on as soon as I get to it is Title VI of the Civil Rights Act of 1964. How many of you are familiar with Title VI of the Civil Rights Act of 1964? How about the Voting Rights Act? How about the Fair Housing Act? All of these are civil rights statutes that affect the social determinants of health, but only affect it to the extent that you and I are willing to enforce them. And may I say, only affect the social determinants of health to the extent that we are willing to fight against the dismantling of the social determinants of health equal protection. So here we have the signing of Title VI of the Civil Rights Act. It has worked. It has worked to desegregate hospitals. It has worked to replace hospitals and provide services when hospitals closed in poor and minority neighborhoods. And because it has worked so well, the United States Supreme Court has done a wonderful job of trying to dismantle it. The most recent example is in the United States Supreme Court's decision in not only Alexander v. Sandoval, but the case that we are going to talk about for the rest of this time together. It is the affirmative action case called Students for Fair Admission versus UNC and Harvard. All right, let's talk about that decision. You know it as the law that dismantled affirmative action. That's one of the biggest misconceptions that is being perpetuated today. This decision severely narrowed affirmative action, but in fact, it did not end affirmative action. Well, I should say that it only ended it to the extent that we let it. These 6 justices certainly are a part of what I would consider to be a concerted effort to end the access that we have achieved because of affirmative action for Blacks, for Latinos, for Native Americans, and in fact, for women. Their decisions looked at the law and decided that equality is no longer necessary, not enforced by law, because we've come so far, they assumed and they argued. We've achieved so much that there is no more discrimination, there's no more differences in the social determinants of health, in education, in wages, in jobs. But there was one among those justices who said, I dissent. And I submit to you that along with Justices Elena Kagan and Sonia Sotomayor, from the South Bronx, by the way, Justice Ketanji Brown Jackson engaged in not only a dissent, but one of the most articulate examples of legal epidemiology that the law has ever seen. So legal epidemiology, it's a term that I didn't coin. I remember learning about this when I was doing my PhD, and the light bulbs went on. This idea that we could look at the statistics of epidemiology and see how law was connected to them. Well, that's exactly what Justice Jackson did. In her dissent to the affirmative action decision that I'll call Harvard and UNC because I don't want to give credence to the name of the plaintiff. I think it is a misnomer. I don't think fairness was what they were after. But what she did was take that 14th Amendment that I introduced to you as one of the Reconstruction amendments. And she looked at all of the statutes that resulted from it, all of the equal protection legislation that flowed from it. And she said that legislation has improved and reversed discrimination. It had a racial basis and a racial objective, racial equality objective. And then she said not only has that legislation worked, but it has worked also today to reverse unjust tax laws, disparate environmental laws. So she did her legal work carefully, thoughtfully, meticulously. And then what she did was connect it to the social determinants of health outcomes. In other words, she did what epidemiologists have done. That is, she took the law and connected it to the social determinants of health to show how health outcomes would be detrimentally and adversely affected by this decision to dismantle affirmative action. So she talked about wealth gaps that would result after this decision reduced the number of lower income and minoritized populations that would be able to access higher education. She also talked about the education gaps that would result. And after doing both of those long-standing and important analyses, what she ended up doing was talking about the health impacts that would result. She talked about the fact that Black children have a higher and elevated blood level, twice as high as white children. She talked about heart conditions, infant mortality. She talked about death rates due to prostate cancer. And this is a justice of the Supreme Court. In other words, she ran the scientific data and connected it to the legal decisions that were being made to dismantle higher education. I end with some recommendations. And the recommendations are simply this. They're all asking you to do what Justice Jackson did when she dissented, to see the essential need for a partnership between science, medicine, education, and the law, to look at the fact that the civil rights laws that will eradicate unjust discrimination are necessary to be taught not only in law school, but also in medical school. Not only in medical school, but also in schools of public health. We can no longer educate physicians and clinicians and practitioners of science to think that they have nothing to do with civil rights. History tells us differently. This is a picture of the Medical Committee of Civil Rights that marched, that put their lives on the line to make sure that there was a Civil Rights Act of 1964, that there was a Title VI, that the Congress heard and passed a Voting Rights Act or a Fair Housing Act. And this is the way that I hope you will hear my clarion call for us to join together medicine, public health, science, and the law to fight for civil rights in each of the social determinants of health. This is not the first time that it was done. If you will have the courage to identify structural racism as one of the primary causes, not only in theory, not only in data, but also to act on it, to recognize that what we must do is partner together, that I thank you again for inviting me as a lawyer to speak to this august crowd of scientists, of clinicians, of people of the background very different from my own, but recognizing that structural racism does two things, and it does two things efficiently. It not only sorts us, you are better than me, hierarchically, but it allocates every one of the social determinants of health. And that is what we have to fight. A very high price was paid. And unless we continue to integrate public health into medical school education, unless we take seriously that each of the social determinants of health is not just a theoretical construct, something to talk about, but that medical practitioners, clinicians, medical public health experts, scientists are responsible, along with lawyers, advocates, community members, to engage in the same struggle that is pictured here. We really aren't serious about public health. We really aren't serious about public health equity unless we're willing to pay the price that these have paid before us. So I'll close with a statement by Norman Daniels, that is, health is a byproduct of justice, and if we are serious about equity in health, we must be serious about justice. These are all connected. Just as these redwood trees appear to be standing solo by themselves, in fact, underground, their roots are connected. And that is the way, the only way, that we'll achieve health equity, by uniting medicine, science, public health, and law. Thank you. So now let me bring out the panel. I have the distinct pleasure of introducing Dr. Joan Y. Reid. I'm just going to, because it's so exciting to do so, let you know that she's an MD, an MS, an MPH, and an MBA. That's a whole lot of M's, right? Dr. Reid is the Dean for Diversity and Community Partnership at the Harvard Medical School. She's the inaugural holder of that position. Since 2002, she has been a path breaker, advancing underrepresented members of the faculty and supporting them with infrastructure, programs, and innovations. She has advanced faculty and community partnerships and outreach, and incentivized students, residents, scientists, and physicians, all to support underrepresented and underrepresented and underpaid, underrecognized, underrealized people in the communities that are served by Harvard Medical School and all physicians. She's been a member of the Massachusetts government, she's been a member of the federal government, and you and I have the honor of calling her our moderator today. Please welcome Dr. Joan R. Reid. Underrepresented everything.
Thank you very much for that warm introduction, Dean Bowen Matthews, but more importantly, thank you for setting the stage for today's panel. Today's discussion about dissent and ensuring equity in public health education, for setting a stage that says it's a time for science and medicine and education and law to come together. And with that, I'd like to introduce the other panelists. Dean Ayman El-Mohamdes, who's Dean of CUNY Graduate School of Public Health and Health Policy, a pediatrician, a public health academic with a commitment to public service and community engagement. Dean El-Mohammed. Also joining this panel is Valerie Montgomery Rice, who is president and CEO of Morehouse School of Medicine. Dr. Montgomery Rice has a career dedicated to the creation and advancement of health equity and has a combination of expertise in patient care, medical research, and organizational management. President Montgomery Rice. And Dr. Laura King, Executive Director, Council on Education for Public Health, whose career has focused on bridging the gap between the needs of the public health workforce and academic public health. Dr. King. And I'm going to join them. So we had the introduction to this panel that talked about our disciplines coming together in ways that work towards health and justice and how they are intertwined and so very related. And also some background, some history for how we got to where we are today. And I like your talking about Harvard, North Carolina. I understand you're leaving out the names of the plaintiffs and the other parts of this. But when we think about where we are today and this, what oftentimes is called this risk to affirmative action, this turning back on affirmative action, I think there's a piece of us not really understanding of where we actually stand, how far we've come or not come. And so we'd really like from the panel to give us their thoughts in terms of where are we? Has everything been addressed? Is it time to let this go? Or is there more work to be done? And I'm going to start with you, President Montgomery Rice.
Clearly, we are not where we would desire to be. Yes, we have made progress. Look on the stage. We have diversity represented here. But when I look at the fact that depending on which box you check, about 13 to 14% of the country is African American or Black, depending on what indication they give in the box. And I look at the fact that only 5.9% of the physicians that practice in this country would check a similar box. When I think about public health persons who are practicing either at the undergraduate level or for the master's degree, I think it would be somewhere around 9%. So we still have a ways to go. Now, that only matters, though, if you believe that diversifying the healthcare workforce makes a difference. And I think many of us who are sitting in this audience have seen clear evidence that it does make a difference in health outcomes and the experiences that those in the community have when there are people who come from those communities who advocate for them. So while we have made progress, until I can see a reduction in maternal mortality, where I see a narrowing of the gap, until I see a reduction in infant mortality, until I see redlining not influence the environmental opportunities that communities have to have clean water or to be pollution-free, until I see a narrowing of the gap between whether it's based on race or gender, I am going to continue to advocate for us educating and training the healthcare, the biomedical science, and the public health workforce that the country needs in order to achieve health equity.
Thank you. Dean Alhamada.
Well, I mean, we really need to look at the statistics, and the question is exactly as you pointed out. What statistics are we looking at? Today, 75% of students in schools of public health are women. But when you look at leadership positions in public health, the vast majority are held by white men. Today, when you look at students in public health in general, you'll say that African Americans, Latino Hispanics, and Asians represent somewhere each around 13.5, 14.5, or 15%. But then when you look at very specific groups, I want you to think for a minute, what percent of doctoral students around the nation are black males? You think it's 13%?
No.
You're wrong. You think it's 10%? You are wrong. You think it's 5%? You're still wrong. African American males today in doctoral programs in the United States are barely 3%. The same to be said for Hispanic and Latino males. These percentages are alarming. You're talking about equal opportunity as though the gates had been flooded, but we're talking about 3%. These are the faculty of the future. These are the role models for a future generation of students. Do you understand the crisis we are in when we are told we cannot preferentially admit? This is without any restriction. We are suffering from a crisis. And that is what we need to think about in the future.
Thank you. Dr. King.
Well, I think we've made some progress. I'm looking back over the last 20 years when I started in the accreditation world. We really struggled with student diversity at all. We were down in the teens of students of color, and that's not disaggregated the way that Dr. Almohandes was talking about. Where I think that we really have some work to do is within our faculty ranks. The Association of Schools and Programs of Public Health 2022 data report reported that 38% of our public health faculty are faculty of color. Again, not disaggregated, so the numbers are certainly worse when you're talking about Black or African American faculty or Hispanic faculty. So I think while we've made some progress in the area of students, in part because we can do preferential admissions, I think we have a long way to go when it comes to faculty.
Thank you. You know, we have up here on our panel sort of law, medicine, and public health, but we also have representation from our historically Black colleges and universities, our Hispanic serving institutions, our MSIs, and any special role there. And Dean Bowman-Matthews, when you think about this decision that's just come down, this SCOTUS decision, we think about where we have come with affirmative action and where we need to go. Is there a special role that these minority serving institutions have played or should play into the future?
Without any question, there is. The fact of the matter is that the leaders of the medical profession, the leaders of the legal profession have come from the ranks of HBCUs, and they still will be responsible for, without the angst. I am the dean of a predominantly white law school institute, PWI, without the angst that we will be facing to admit students, to create pipelines. But I want to say that the job is not theirs alone. I want to cite some of the success that happened in California. So we have the Supreme Court decision. It is a tragedy and a travesty. But immediately after Prop 207 was passed in California, the numbers of Hispanic and Black, specifically medical students, plummeted. But the medical schools, PWIs, as well as Hispanic serving in historically Black schools, did not stop standing on their values, did not stop defending the need for protecting the educational benefits of diversity. And instead, they changed to mission-driven admissions. They changed to mission-driven financial aid. And they changed what was attracting students so that since the 1997 Prop 207 was passed, we have seen the numbers of Latino and African American and Black medical students in California now exceed what it was before Prop 207. So there are ways to get this done. Affirmative action can end, but the values should not end for HBCUs and for PWIs as well.
Thank you. I think an important part for this, for me also, is an understanding, even as we talk about the end of affirmative action, however we want to frame that, it does not mean that our institutions need to give up on their missions, on their values, and it does not mean that the students that would be applying need to think there's not a place for them. And that's one of my major concerns, that this sense that it's over, and it is not over. And so as we look at this decision, there are still doors open for us to continue down a path towards real inclusion and real equity and justice in medicine and in public health and in law, because these issues also exist in law. When we think about this recruitment, what has Morehouse done? What has happened in this space, and what examples can we learn from that?
So Morehouse School of Medicine is 48 years old. We were founded to diversify the healthcare workforce in the state of Georgia, to work toward the elimination of health disparities, and to improve access in the state of Georgia. When it was founded in 1975, there were approximately 93 Black physicians in the country that were, in the state, that were caring for about 75% of the population. And it was started around the same time another school was started, Mercer University. Mercer was required to enroll all of their students from the state of Georgia. Morehouse School of Medicine was not, because we knew that we couldn't diversify the healthcare workforce if we only enrolled students, Black students or Latino students who applied from the state of Georgia, because the number was so small. And so you talk about recruiting and admitting for mission. That's what we've always done. Morehouse School of Medicine uses a set of what we describe as adversity scores, 10 of them that align with socioeconomic factors, first generation, college students, etc. Students self-report. Race is not one of those. We've never had to use race as one of the admission criteria for coming to medical school. And throughout this, we've seen more students of diverse backgrounds beyond Black and African American or Latino to begin to apply to Morehouse School of Medicine, because you begin to see that white students who come from rural communities have equal socioeconomic challenges and have those adversity scores that align with our mission and value. And they end up going back and practicing in those underserved communities at equal rates to our Black students. They go back and they go into primary care, or critical core specialties like surgery, ER, or OBGYN in this state. And we see this with those students based on the distance traveled, their life experiences, and how they want to contribute to achieving health equity. So for us, we are seeing an increased number of applications. That is not surprising to us. But you said something that was very important. Minority serving institutions and HBCUs cannot do it alone. PWI institutions who particularly have in their mission statement a commitment to diversity, ought to live into that commitment to diversity. We saw in the last 15 years with over 15 to 20 new medical schools coming online, many of those were PWI institutions, and they only moved the needle 0.05% for the number of Black and brown students who attended the medical school. So they are not necessarily, in my opinion, living into their mission, and we can't do it alone. We need all of us to live into our missions, particularly if we are committed to achieving health equity.
Thank you for that. I also want to point out, because it's important that you talked about the roles that these graduates play in community, in serving populations, in improving health, but also the role they play in terms of leadership, historically and currently, and as we move forward, in ensuring that there is a seat at the table and a voice at the table as policies are changed and practices are changed. And so I want to bring this forward, that it's not just an issue of who practices medicine, but who also who teaches and who leads. With that, I want to really turn to talking more about it's not just race or ethnicity, and this importance of life experience. And maybe, Dean, you could talk about that.
Yeah.
What does that mean?
Yeah, first of all, I just wanted to consult my dear Dean of Law and say that the SCOTUS decision did not restrict recruitment. It just restricted admission. Am I right?
That is absolutely correct.
Thank you. So I'm looking at you from Schools of Public Health, and I'm telling you, we need to double, triple, quadruple, quintuple our efforts at recruiting students from diverse groups, because the Supreme Court does not prohibit us from doing that. Go to the schools, go to the communities, go to the undergraduate programs and draw them to you. Tell them how important their mission is going to be. I tell many of my faculty, number one, we have done away with standardized testing, because we know at the bottom of the story these are racist, and they prevent students of color from attaining grades that are competitive compared to other groups. I've experienced that with my own kids who went to special classes to improve their performance. God bless them, they are very smart. But nonetheless, when they took these classes, their scores improved. Number one. Number two, I tell my faculty that these students are coming in with a master's degree already. You know what the master's degree is called? Life. They lived that experience. Number three, you need to understand that admitting these students into our programs enriches our program. Change that narrative around. We're not doing them a favor, they're doing us a favor. You don't want to bring them in as students with special programs? I would say hire them as consultants, and maybe they can attend the classroom. The importance of bringing in students of diversity is not only for them and where they're going to go and what communities preferentially they are going to serve, but it is about the entire classroom experience. It is about the discussions that occur, the insights, the heart, the understanding, not only of life circumstances, but what could work and what could not work. They help elevate the classroom to a level of reality testing towards populations that we serve. We need to be grateful to them, and we need to understand that they need to feel appreciated, loved, and respected. Finally, the last point. Representation of faculty has not been as successful as recruiting public health students of diverse backgrounds and underrepresented minorities. These faculty are a valuable commodity. Faculty of color, faculty of diverse backgrounds will attract students to our programs and will be good role models. Treat them well. Support them. Their success is our success. That's all I wanted to say.
Thank you. Dr. King, as we think across schools of public health, what would be your message to our schools as they think about this new season of recruitment and admissions?
Yeah, I think it's really important to know that, to recognize that post-SCOTUS decision, what I've heard a lot of from schools and programs of public health is a real fear and reluctance and kind of not knowing what they can do. And I think that there are a lot of outside groups trying to make the decision into more than it really and truly is. As Dr. Almohanda said, you can still recruit students. And you can still emphasize students of color. You can develop pathways and pipeline programs. I just attended earlier today a session from some folks in Kentucky. It was a partnership with the universities in Kentucky and the Kentucky Department of Health, and talking about some pipeline programs, some dual enrollment programs, specifically working with certain high schools. But I also think that it's important for them to remove some barriers. And we heard about standardized test scores. Another one would be application fees, for example, are barriers to admission. At the undergraduate level, there are some prerequisites that are barriers to admission. Not every high school in the nation has access to advanced calculus, for example, or AP physics. And when that is included as an admission requirement, it creates barriers. Early decision programs. A lot of highly selective institutions fill a great proportion of their classes with early decision students. And for those of you who don't follow that closely, that means that students and their families have to essentially sign a contract that they're going to come to that institution prior to receiving the financial aid package. So you can imagine that for students from lower income families, that's a commitment that they simply can't make. And so that is a barrier to them. Legacy admissions, we can talk about that, and how that creates a barrier for students. So I think institutions can do a lot to eliminate barriers, or at least reduce barriers, as well as do affirmative work toward a diverse student body.
Thank you, thank you. There's a piece of this, and you alluded to it, of this overinterpretation or misinterpretation of this ruling. I oftentimes hear it in terms of this confusion between Title VI and Title VII, and people trying to extend this ruling into other spaces. And I was hoping maybe you could help explain part of this so we could better understand. Title VI, for me, this was about undergraduate education. It wasn't about who I hire.
Title VI is not about who you hire. Title VII is about who you hire, but make no mistake about it, the people who have come after Title VI are coming after Title VII also. So this is a very narrow decision, as you have said. It has only to do with admissions and race-conscious admissions in higher education. There is, as you have said, a concerted effort to enlarge it. After the decision was made, what did the headline say? Affirmative action is over. That's not what the decision did, but that's part of the propaganda. And so it will take courage and commitment. It will take a steady hand to recognize that this agenda has been in the making for 20, 25 years. I still believe that good overcomes evil, and I still believe that we can say to this country, if you want to be who you say you want to be, right? If you want to be the country in which all are created equal and endowed with inalienable rights, if you want to be the country where equal justice really is available under the law, then we have to fight for it now. We have to fight for it like never before, because it is truly under attack. Even though this decision only has to do with admissions, there are decisions in the pipeline that have to do with Title VII, employment. There are decisions in the pipeline that have to do with financial aid. And so we are going to have to stand our ground. I want to say that there is another magic bullet, if you will, in the medical profession. And that is, we can say to the country that healthcare for all is better when healthcare is diverse. Now, we see a lot of data that tells you that corporate boards make better decisions when women are on the corporate boards. We see a lot of data that tells us that diverse leadership in organizations such as educational organizations actually produce better educational outcomes. Well, the data is unassailable that a diverse workforce produces better health outcomes, and that's for everybody. People who are white, people who are black, people who are Latino die quicker, get sicker in environments that are racist. And if you are serious about the health of the entire population, then it is important to diversify your workforce through education.
Absolutely.
Thank you. As we've talked about this decision, which is not an end to affirmative action, so I hope we change even the language about that, because it is propaganda. And we've talked about this role of recruitment and what is in that sort of bucket of recruitment. And I would talk a little bit about holistic admissions, as you talked about these other characteristics. But it can mean more than this. So it's not just how do people get into our institutions, it's also what happens when they get in there, and the environment and the culture and the climate. And I'd ask you to speak to this. How do our institutions need to change or modify to ensure the success of all?
I think Dean talked about it here. It's, first of all, any of us who go into a new environment, when we walk in and see someone who looks like us or who sounds like us, if you're from the South, who sounds like us. I never forget, my first week at Harvard Medical School, coming from Atlanta, Georgia, coming from Macon, and I get on the elevator and I said, "Can you mash too?" Okay, now, that was totally acceptable in Georgia. Everybody knew exactly what I was talking about. And so how comfortable and uncomfortable did I feel when someone said, "Is mash really a word?" And I was like, oh, okay, this is where I am. But having some level of likeness always makes you feel welcome. So having faculty members, having other support persons, because I always tell my students, and I tell my faculty this, the learning environment is not just created between the professor and the student. The learning environment is created by everyone in that environment. And having a diverse workforce there, meeting the students where they are, giving them an inspirational talk before that exam, someone in the cafeteria, slipping them an extra cup of coffee, all of those things increase the welcoming environment. And so as a leader, one of the things that I think we should do is promote more engagement and more accountability to the learning environment that we create for our students. And yes, we think about it mostly with diversifying the faculty, but I also think diversifying the workforce, the entire workforce, and then the experiences that we select for our students to have. The hospitals where they're going to have their third and fourth year experiences. What I love about our Masters of Public Health is that our students are out in the community the first week, which was a little bit surprising to me that they get thrown out there in the first week and they have to co-create solutions with the community. But they can't co-create a solution with the community until they first begin and understand how to listen to the community. And that's taught in the classroom, but it's taught in that experience. And so the experiences that we create for our students to understand what the real world is going to be like when they're out there practicing or advocating for a community or creating the next new drug. They need to have a picture on their bench, on their lab bench, who is going to be the recipient of that new drug that they're going to discover 15 years from now. So they always have a connection to the purpose. And I believe that that comes about when you have people who have had diverse life experiences, educated and trained in people who have had diverse life experiences.
Excellent.
Could you speak in the public health space? When we think about public health, population health, health policy, this critical importance of that learning environment, that research environment?
Absolutely. And I will tell you that none of us is completely absolved from examining within. Issues of microaggression are not minor. We have to monitor our own behaviors, examine how we treat people, see things from their perspective, make available safe space where they can express experiences that have been hurtful or isolating, but make sure that we have ways to remedy these things so they don't feel that they are in an echo chamber. So self-examination, improving, and not feeling, a chip on our shoulder by saying, okay, this is something I was not aware of. I mean, the word that you used, I have no idea what it means. But, I grew up in Egypt, so I'm excused.
Like you mashed the potato, mash.
Yes, understood. I get it now. I'd never heard that. So the question here is that we have to be also respectful of other cultures. And like we treat people that are coming from other countries, say Paris, France, or Munich, Germany, our ability, our willingness to accommodate for cultural differences seem to be greater to people coming from the outside than they could be for people from our own family, within our own community, or trying to understand, or trying to relate. And then we have a lot of misconceptions. Do I have a moment to tell you a story?
A short story.
A true story. A true story. Okay, there are these misperceptions, and they are nefarious, that bringing students of color means that you have a student that could potentially want to take advantage of the environment where they're in. Such an unforgivable bias. During the COVID pandemic, we had a student in our school, and many students were finding difficulty. 80% of our students at CUNY School of Public Health are employed, and 60% of them are employed full-time. 65% of our students are students of color. So during COVID, with all the difficulties in employment, in housing, etc., we created an emergency fund. Okay? Here I have this young lady from a minority group, an African-American young lady, like New Yorkers do, moved in with a total stranger, like they do, a housemate, okay? All right, so she has a housemate, a roommate, who gets COVID, and during the very early stages of the disease, passes away.
Oh.
It's not like her sister or her lifelong friend, or they've been to school together, but there she was, faced with a situation where she was alone with a roommate, and she passed away. And they searched far and wide for anybody that could take responsibility for expenses around burial, could not find them. Our student paid the expenses and could not afford to pay tuition. For the first time, she was a 4.0 student. For the first time, couldn't pay tuition. We went to her with that emergency fund and said, so and so, we understand that you're not paying, that you're about to graduate, you didn't pay tuition, what's the story? So she says, I'm very sorry, there was an emergency, described as a family emergency, and I had to cover expenses around death, and I couldn't pay tuition. We offered her the emergency scholarship. You know what she said? She said, no, I don't need that money. Give it to somebody who needs it more. He said, take tuition. Take that money.
So I think he makes a very good point. And that is, I'm going to go out on a limb. I think I'm going to do it this way. I'm going to criticize the legal academy and see if it's true of the medical academy, of the public health academy, right? Because if we're serious, we have to do business differently, right? In the legal academy, we talk about diversifying our faculty, but somehow mysteriously, at the very last minute, the Latino, the Black, the Native American candidate makes it to the last round, but can't cross the finish line because they didn't come from the right school or have the right clerkship or the right standard. Change the standards. If you're really serious about diversifying the faculty, change those standards. Somehow or another, we find ways to promote people as leaders in the dean ranks, leaders in the administrative ranks, vice provosts, but we somehow find that we cannot find enough Latino, African Americans to change the leadership ranks in predominantly white institutions. We have to change our admissions criteria. We have to change the fact, we know that financial aid is one of the truest predictors of a low performance on admissions tests. Certainly for LSATs, I don't know about MCATs and GREs, but certainly for LSATs, stop using the test. Stop using the test if it is the criteria that is weeding out people based on their finances, because all we're doing is replicating privilege. Change the curriculum. Change the criteria. If we're serious, we have to do business very differently inside of our institutions, not just outside of them.
Absolutely.
What I'd like to add a component to this, because this is not about change and moving away from excellence. This is about excellence and inclusive excellence, and actually challenging our beliefs and our myths about what counts and what doesn't count.
Yes.
And actually moving to a place where the missions and the values we put forward are reflected in the kind of criteria that we use in terms of who we admit and how we advance individuals. So a next step of this, and with this, an understanding of the importance that even as we do all of these things, is the critical importance of monitoring the impact of these changes. And the SCOTUS decision did not say that we can't collect data. It did not say that we cannot monitor. And so critically important for us to look at the evidence and then to make adjustments, sort of that quality improvement stance as we move forward. As I look at the time, and I want to ask each one of you briefly, just in order, what do we risk if we don't intentionally advance equity? If we don't intentionally move our institutions in ways that enable us to seek justice, to support equity and health? What's at risk for all of us, from the legal side, from public health, from medicine? Start with you.
I think what's at risk is the health and heart of the country. I honestly think that the health and heart of the country will die if we do not, here and now, in this room, make the commitment to fight for diversity, to fight for equity, and to fight against what the legal profession is doing to both of those causes.
Thank you. Dean Elman-Hamdas.
I'm totally convinced that we lose, we do not win. We have to be able to verbalize that in a scientific manner, in a logical manner, and in a socially applicable manner to describe and explain what we are losing. And what we are losing is beyond representation. It is losing our own efficacy in training and graduating the next army of public health professionals that are going to change the future of this country. Do you know that SCOTUS has one exemption from this ruling? My Dear Professor Dean, can you tell me what this exemption was?
The military.
The military. We are military, but we are military for good, we are military for health. That is unbelievable that people do not understand that what is applicable to the military as an exemption is not applicable to us.
Yes.
That the role that we play in protecting the safety of this nation is just as valid as the role that an army would play, and that diversity that is allowable in military academies should be applicable to us. So the second thing is, what should we do? We should speak up, continue to speak up, continue to advocate for our rights as training institutions to fulfill our destiny and enhance our efficacy. We should change the narrative, like we were doing somebody a favor, to we are now hampered from doing ourselves a favor. That we are primarily the institutions that are being hurt.
President Montgomery Rice.
So the dean really captured many of my thoughts here. The military can get an exemption for the good of the country. And we have such health disparities. And we understand that race concordance, gender concordance, other factors that are concordant between the patient and the provider leads to improved health outcomes. How could we not have an exemption for medical? And then included in that, to me, of course, is public health officials. I am really concerned that if we see a continued drop in the number of diverse providers, that we will see an even widening of the gaps around health and health outcomes. I know we can do better than this in this country. We already are predicting over 100,000 physician shortage in the next 7 years. And if Black and brown people use the healthcare system at similar rates to white people, then that is only going to increase by about 38% that provider shortage. We can do better, we must do better, and so we have to do exactly what happened in California. We have to raise awareness and create pathways and programs for Black and brown students to apply at even higher rates. Bombard the system such that the answer can never be no, or we can never see a decrease because so many people are applying who are overly qualified.
Thank you. Dr. King?
My colleagues have really said it all. One thing that I think that we will lose if we don't keep at it is our learning environment in schools and programs. It has improved over the last 20 years, in large part because it is a much more diverse place in which to learn, and I don't want us to sacrifice that learning environment.
Thank you. Please join me in thanking all of our panelists today. One of the things Dean Bowen Matthews ended with is health is a product of justice. What we're talking about here is not how do we help one person, we're talking about how we help the collective. How do we improve the health of the collective and all? It's not, the burden should not be on the Black or the brown or the marginalized. The burden is on all of us to address the systems that are in place to make sure that we move forward towards equity, towards justice, towards inclusion, that we don't do this in isolation. This is not a problem of medicine or public health or law or science alone. It's all of us together are in this struggle. So my hope is that all of you join us in creating the change that's needed to ensure that the workforce of tomorrow reflects our population and is responsive to the needs of our country as a whole. Thank you to our panelists. Thank you for being here today. And now we'll turn it back over to Dr. Benjamin.
Dr. Reed and panel, what an amazing, amazing conversation. I think what I heard was affirmative action is not dead, that I can't believe I'm saying this, that public health people and lawyers ought to get together and we can solve this problem together collaboratively, that we need to build a pipeline, that need-based admissions absolutely is essential, and that building the faculty is absolutely an important tool. So with that, I want to thank you all. Give this panel another round of applause. Please don't forget to complete the session surveys in the APHA 2023 mobile app by 7 p.m. today to be entered to win a Starbucks gift card. And don't forget the fact that we have our closing general session on Wednesday afternoon. And, you know, tonight is Monday night. It's party night, lots of receptions. Everyone, please have a good time, but do so very safe. Thank you.